With hyperprolactinemia, hyper means above. Prolactin refers to the hormone produced by the pituitary gland, and emia refers to the blood, so hyperprolactinemia means higher than normal prolactin levels in the blood. Normally, at the base of the brain, there's a small pea-sized gland called the pituitary gland. The anterior pituitary, the front of the pituitary gland, has a number of different cells, each of which secretes a different hormone. One group, the lactotroph cells, secrete prolactin. In men, excess prolactin decreases testosterone production. In women, during pregnancy, elevated levels of estrogen stimulates the lactotrophs to produce large amounts of prolactin, which stimulate alveolar cells in the breasts. In response to prolactin, the alveolar cells divide and enlarge, and once a baby is born, lactogenesis begins, which means that milk is being produced. Apart from milk production, high levels of prolactin also inhibit the release of gonadotropin-releasing hormone from the hypothalamus, which results in decreasing luteinizing and follicle-stimulating hormone levels, which in turn decreases estrogen levels. In women, this can stop ovulation and menstruation, which is why women typically don't have a menstrual period while breastfeeding. In women that are not pregnant or breastfeeding, and in men, prolactin levels are usually kept in check by the hypothalamus in two ways. The first way is the most important, and it's when the hypothalamus secretes a constant stream of dopamine, which is also called prolactin inhibiting factor. Dopamine binds to specific receptors on the lactotrophs and inhibit the release of prolactin. The second way is when the hypothalamus secretes thyrotropin-releasing hormone, also called prolactin-releasing hormone, which can stimulate prolactin's release. If the levels of prolactin rise for any reason, then it signals the hypothalamus to release more dopamine, eventually decreasing its own production, a process called negative feedback or feedback inhibition. Hyperprolactinemia can develop a few different ways. The first is physiologic hyperprolactinemia, which is what happens during pregnancy and lactation, and levels of prolactin typically return back to normal afterwards. Another cause is prolactinoma, a type of pituitary adenoma, a benign tumor of lactotroph cells which usually grow uncontrollably and make excess amounts of prolactin. There are also systemic causes of hyperprolactinemia, like hypothyroidism. In hypothyroidism, the hypothalamus tries to boost the production of thyroid hormones by releasing more thyrotropin-releasing hormone. That leads to higher levels of prolactin. Another cause is medications. As an example, dopamine antagonists oppose the action of dopamine, and that removes the inhibition on the lactotroph cells and leads to elevated prolactin levels. Other medications include estrogens, which directly stimulate the lactotrophs to produce more prolactin. A rare cause of hyperprolactinemia is damage to the hypothalamic pituitary stalk, which contains the blood vessels that connect the hypothalamus to the pituitary gland. The damage can be due to trauma, nearby tumors, or due to brain surgery. In these situations, there's no way for the dopamine from the hypothalamus to reach the lactotroph cells. Symptoms of hyperprolactinemia in women include galactorrhea, which is the increase in milk production, and anovulatory amenorrhea, in which there is an absence of ovulation and menses. In men, symptoms of hyperprolactinemia include gynecomastia, or breast enlargement, and erectile dysfunction. In addition, a prolactinoma can physically press on optic nerves, causing headaches and impaired vision. Hyperprolactinemia can be diagnosed by detecting high levels of prolactin in the blood. Typically, a pregnancy test is done to check for a physiologic explanation, and a brain MRI is done to look for prolactinomas. Treatment varies based on the underlying cause of hyperprolactinemia, but it generally involves giving dopamine agonists like cabergoline or bromocriptine. Of note, medical treatment is also effective if the underlying cause is a prolactinoma. Alright, as a quick recap, hyperprolactinemia occurs naturally due to pregnancy and lactation, and can stop ovulation and menstruation during that period of time. The most common pathologic cause is a pituitary adenoma, where lactotrophs grow uncontrollably and secrete prolactin, causing headaches and impaired vision. In addition, in women it causes galactorrhea and anovulatory amenorrhea, and in men it can cause gynecomastia and erectile dysfunction.
Pituitary adenoma can be broken down into adeno, which refers to a gland, and oma, which refers to tumor. So pituitary adenoma is a tumor that develops in the hormone-producing cells of the pituitary gland. Normally, the pituitary is a pea-sized gland, hanging by a stalk from the base of the brain. It sits just behind the eyes near the optic chiasm, which is where the optic nerves cross. The anterior pituitary, which is the front of the pituitary gland, contains a few different types of cells, each of which secretes a different hormone. The largest group of cells are the somatotropes, which secrete growth hormone, or GH for short, which goes on to promote tissue and organ growth. The second largest cell group are the corticotrophs, which secrete adenocorticotropic hormone, or ACTH. ACTH stimulates the adrenal glands to secrete cortisol, which is a hormone that controls the stress response as well as metabolic regulation. A smaller cell group are the lactotrophs, which secrete prolactin. Prolactin stimulates breast milk production and also inhibits ovulation, which is when an egg cell is released from the ovary, and inhibits spermatogenesis, which is the development of sperm cells. There are also thyrotrophs, which are cells that secrete thyroid-stimulating hormone, or TSH, which goes on to stimulate the thyroid gland. And finally, there are also gonadotrophs, which secrete two gonadotropic hormones, luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH, both of which go on to stimulate the ovaries or testes. In pituitary adenomas, one of these cells mutates and becomes neoplastic, meaning that it starts dividing uncontrollably and over time it forms a tumor. But these cells don't invade neighboring tissues, so this is considered a benign tumor rather than a malignant one. Pituitary adenomas can be classified by their size. Adenomas smaller than 1 centimeter are called microadenomas, and those larger than 1 centimeter are called macroadenomas. Macroadenomas are more likely to compress surrounding structures, like the meninges, which is the protective layer overlying the brain that typically causes pain when it's stretched. Macroadenomas can also compress optic nerves as they cross at the optic chiasm, and that can affect a person's ability to view things that are in the temporal visual field of both eyes, also called bitemporal hemianopia. Finally, the compression can also affect other healthy pituitary cells and interfere with their ability to make hormones. Pituitary adenomas that secrete hormones are called functional adenomas, whereas those that don't are called non-functional adenomas. Functional pituitary adenomas are divided into a few different types, depending on the cells that they arise from and the hormones these cells produce. The most common type of pituitary adenoma is a prolactinoma, which arises from lactotrophs that make prolactin. In women, excess prolactin causes amenorrhea, which is when there's a loss of menstrual bleeding, and galactorrhea, which is a milky nipple discharge. In men, excess prolactin causes a low libido, which is a low sex drive, as well as gynecomastia, or breast enlargement. The second most common type of pituitary adenoma arises from somatotropes that make growth hormone. In children who haven't had fusion of their epiphyseal plates, which are the parts near the ends of long bones where new bone growth takes place, this type of adenoma causes gigantism. In gigantism, there's an increase in body size and height with disproportionately long limbs. In adults who've had their growth plates close, this type of adenoma causes acromegaly. In acromegaly, there's enlargement of the bones of the skull, hands, and feet. In both gigantism and acromegaly, excess growth hormone causes enlargement of visceral organs, like the heart. In fact, a serious complication of growth hormone secreting adenomas is heart failure, due to an enlarged heart that has very little room for blood. The third most common type of pituitary adenoma is an adrenocorticotropic hormone secreting tumor, which arises from corticotropes that make adrenocorticotropic hormone. The excess adrenocorticotropic hormone stimulates the adrenal glands to make excess cortisol, leading to Cushing's syndrome. Cushing's syndrome can result from a number of causes, and when it develops due to a pituitary adenoma, it's specifically called Cushing disease. Cushing's disease causes a variety of symptoms, including a change in fat distribution, which creates moon facies, a round, full moon-shaped face, as well as buffalo hump, a fatty hump on the lower back, and truncal obesity, where fat gathers around the abdomen and trunk rather than in the limbs. Finally, there can be adenomas that develop from thyrotrophs and gonadotrophs. Thyrotroph-derived adenomas are quite rare, but they can cause excess TSH and, as a consequence, signs and symptoms of hyperthyroidism. These include weight loss despite an increased appetite, heat intolerance, sweating, insomnia, agitation, and tremor. Finally, gonadotroph-derived adenomas rarely secrete hormones, so they're usually clinically silent. In fact, they're the most frequent subtype of non-functional tumors. If they grow big enough, they might cause compression signs, like headache and visual impairment. Diagnosis of pituitary adenomas is based on measuring pituitary hormone levels, and then getting an MRI to image the pituitary gland to see if there's a tumor and estimate the size. The treatment for a pituitary adenoma depends on the type and size. When dealing with hormone-producing pituitary adenomas, prolactinomas are usually treated successfully with medication and rarely require surgical removal or radiation therapy, while somatotrophic and corticotrophic adenomas usually require a transsphenoidal surgical resection, which is when the tumor is removed through the nose and the sphenoidal sinus. When dealing with non-functional pituitary adenomas, only tumors large enough to cause symptoms through compression require surgery. Alright, as a quick recap, pituitary adenomas are benign tumors of anterior pituitary cells, and their symptoms depend on their size and cellular origin. The most common type involve lactotrophs that make prolactin, somatotrophs that make growth hormone, and corticotrophs that make ACTH. They're usually diagnosed by checking hormone levels and getting an MRI, and are treated with medications or surgery.
With prolactinoma, prolactin refers to the endocrine hormone secreted by the pituitary gland, and oma refers to a tumour. So a prolactinoma is a benign tumour, or adenoma, of the pituitary gland that secretes excess prolactin. Normally, the pituitary is a pea-sized gland hanging by a stalk from the base of the brain. It sits just behind the eyes, near something called the optic chiasm, which is where the optic nerves cross. The anterior pituitary, which is the front of the pituitary gland, contains a few different types of cell, and each of them secretes a different type of hormone. One group of cells in the anterior pituitary are called the lactotrophs, and they secrete prolactin. Prolactin stimulates breast milk production. Another group of cells that are found in the anterior pituitary are gonadotrophs, and they secrete two gonadotropic hormones, luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH, both of which stimulate the ovaries in women, which make estrogen, and stimulate the testes in men, which makes testosterone. Prolactin release is controlled by something called the hypothalamus, which is a structure at the base of the brain just above the pituitary. It makes two key hormones, thyrotropin-releasing hormone, which increases prolactin release, and dopamine, which inhibits prolactin release, and actually overrides the stimulatory effect of thyrotropin-releasing hormone. That's why dopamine is known as prolactin inhibiting factor, and it's constantly released to prevent prolactin release in anyone that's not pregnant. High levels of prolactin in the blood sends a negative feedback signal to the hypothalamus, making it release more dopamine, which then decreases prolactin levels. High levels of prolactin can also signal the hypothalamus to decrease the secretion of gonadotropin-releasing hormone, or GnRH. Gonadotropin-releasing hormone acts on the anterior pituitary to make follicle-stimulating hormone and luteinizing hormone, or FSH and LH. Now, during pregnancy, the anterior pituitary gland releases prolactin and the placenta releases human placental lactogen and progesterone, And all three of these hormones stimulate the growth of more glandular tissue in the breast to produce milk. Prolactinomas are functional tumours, meaning that they secrete high levels of prolactin, and they typically form when there's a mutation in the lactotroph cells of the anterior pituitary that allows the cells to divide uncontrollably. The key is in the size with these things. Prolactinomas that are less than 10 mm in diameter are considered microprolactinomas, whereas those that are greater than 10 mm are called macroprolactinomas. Now, macroprolactinomas can compress surrounding structures, like the meninges, which is the protective layer overlaying the brain that typically causes pain when it's stretched. Also, an enlarged pituitary gland can compress the optic nerves as they cross at the optic chiasm. This can cause vision problems, as it affects a person's ability to view things that are in the temporal, or outermost portion, of the visual fields in both eyes. And this is called bitemporal hemianopia. Another name for this is tunnel vision, because the centre of your vision is clear, but everything in the periphery is dark, kind of like looking through a tunnel, I suppose. As well as all the local effects, the prolactin that gets secreted by the pituitary inhibits the hypothalamus from releasing gonadotropin-releasing hormone, which leads to a decrease in follicle-stimulating hormone and luteinizing hormone from the pituitary. Now, this is an issue because it results in less estrogen being produced in the ovaries, and less testosterone in the testes. Low levels of these sex hormones can cause inhibition of ovulation in women and inhibition of spermatogenesis in men. In women, estrogen is also really important because it prevents the activation and differentiation of certain bone cells called osteoclasts. Osteoclasts normally break down bones and release the calcium into the blood. So, with decreased estrogen levels, osteoclasts are free to proliferate, and therefore, women with prolactinomas are at increased risk of fractures and osteoporosis. So, when it comes to symptoms, people with small prolactinomas or microprolactinomas often have no symptoms at all, whereas those with large prolactinomas, macroprolactinomas, might have vision problems like bitemporal hemianopia or headaches where the meninges is stretched. In women, excess prolactin causes galactorrhea, which is milky nipple discharge, amenorrhea, which is missed menses, and vaginal dryness and brittle bones in old age. In men, excess prolactin causes gynecomastia, or breast enlargement, and erectile dysfunction. And both sexes can experience decreased libido and infertility. The diagnosis of prolactinoma is typically based on elevated levels of prolactin in the blood. Sometimes there's also excess thyrotropin-releasing hormone, which may be stimulating the pituitary gland to secrete prolactin. Often, an MRI can be done to visualise the prolactinoma and classify it based on size. To treat prolactinomas, you can use medication or chop it out surgically. Since dopamine inhibits prolactin release, a clever way to treat it medically is with dopamine agonists like bromocriptine and cabergoline, which can be used to inhibit prolactin release. Now, surgery is usually only considered for individuals with macroprolactinomas, or those who fail medical therapy. If complete resection of the prolactinoma is not possible, or if prolactin levels remain elevated after surgery, radiation therapy can sometimes be useful. Okay, we made it, that's it. So let's just quickly whiz over the main points. Prolactinomas are benign tumours of the anterior pituitary that result in the excess secretion of prolactin. Excess prolactin can cause a wide range of symptoms, including galactorrhea, which is a milky discharge from the nipples, gynecomastia, which is breast tissue growth in men, amenorrhea, or missed menstrual periods, and infertility. It's typically treated either with dopamine agonists or with surgery. Hi everyone, thanks for watching that video on prolactinoma. I love the endocrine, as always, so that was really fun to make. The script was written by Royce Rajan, it was edited by Rishi Desai and Ifan Chow, and I was lucky enough to get to do the illustration and the voiceover. And the whole thing was edited by Sam Gillespie, so go team! If you like that video and you like other videos that you've seen on the YouTube channel, and we do have a ton, then head over to osmosis.org, because there are even more videos there that aren't released on YouTube. And there are loads of other things as well, actually, like flashcards and question banks and just basically everything you need to get through med school. I'm not even joking, apart from physical patients. But it's great. Check it out. And also check out our Facebook, Instagram and Twitter. We'd love to hear what you've got to say about osmosis. And if you've got anything that you want to feedback about this video, I'd love to hear it. So pop that in the comments. And I look forward to making the next video for you guys. Bye!
On your rounds, you admit 28-year-old Regina, who presents with an 8-month history of depression, cold intolerance, fatigue, and reduced libido. History revealed she delivered a healthy baby 8 months ago, and that the delivery was complicated by a severe postpartum hemorrhage. She has also been unable to breastfeed and hasn't had her menstruation since giving birth. Physical examination is remarkable for bradycardia, weight loss, and delayed relaxation of her reflexes. Then you see Alexander, a 58-year-old male with difficulty seeing things in his peripheral vision. He also describes a loss of sex drive, erectile dysfunction, and significant weight gain, all starting approximately 2 years ago. The examination revealed moderate obesity, bilateral gynecomastia, and bitemporal hemianopia. Basal serum hormone measurements were performed, showing decreased T4 levels in Regina and decreased FSH, LH, and testosterone levels in Alexander. Both people have hypopituitarism. So, hypopituitarism refers to the decreased secretion of one, some, or all of the anterior pituitary hormones. These hormones are ACTH, or adrenocorticotropic hormone, TSH, or thyroid-stimulating hormone, GH, or growth hormone, FSH, or follicle-stimulating hormone, LH, or luteinizing hormone, and prolactin. Posterior pituitary hormone deficiency can also occur, but it's extremely rare. This part of the pituitary gland releases oxytocin and antidiuretic hormone, or ADH. Hypopituitarism typically occurs because of an acquired or congenital issue where the hypothalamus or pituitary is injured. Now, the clinical picture of hypopituitarism depends on which hormone is missing. First, ACTH deficiency can present with symptoms such as orthostatic hypotension and tachycardia, weakness, and lethargy, especially during periods of stress like illness or during surgery. Stress can also precipitate an adrenal crisis, where the individuals have vascular collapse and shock, nausea, vomiting, abdominal pain, and mental status changes ranging from confusion to coma. Next, TSH deficiency presents with symptoms of hypothyroidism, like fatigue, cold intolerance, depression, bradycardia, decreased appetite, and constipation, as well as dry skin and a puffy face and slow relaxing reflexes. Third, growth hormone deficiency is more obvious in children who present with short stature and failure to thrive, meaning low height and weight for their age. In adults, it can cause a decrease in bone mineral density and muscle mass, and an increase in fat content. Now, for the reproductive hormones. Gonadotropin deficiency results in decreased sex hormone production in both females and males, with different consequences. Premenopausal females can have menopause-like symptoms such as infertility, irregular periods or absent periods, hot flashes, and vaginal atrophy. By contrast, females who have already gone through menopause are mostly asymptomatic because the ovaries are already at rest. Males can have infertility as well as decreased sex drive, erectile dysfunction, low energy, weight gain, and in severe cases, hot flashes. Finally, moving on to prolactin deficiency, which causes an inability to lactate after delivery, which is called agalacturia, absent menstruation or amenorrhea, and cold intolerance. Diagnosis is based on suggestive symptoms and basal serum hormone measurements. However, dynamic testing may also be required in some cases. First, when ACTH deficiency is suspected, an 8 a.m. serum cortisol level and serum ACTH are required, both of which should be low. If results are inconclusive, an ACTH stimulation test with cosentropin, a synthetic analog of ACTH, is required. Serum cortisol is measured 1 hour after cosentropin administration, and if it rises, that confirms a deficiency in pituitary ACTH production. Second, TSH deficiency is based on having a low serum T4 level. Third, a GH deficiency diagnosis is based on insulin growth factor 1, or IGF-1 levels. That's because, although daily growth hormone secretion is pulsatile, it stimulates the liver to release a constant amount of IGF-1 throughout the day, which can be used as an indicator for GH secretion. Low serum IGF-1 levels indicate a growth hormone deficiency. However, this needs to be confirmed by using the arginine L-DOPA combination test, where growth hormone levels are measured before and after giving an arginine hydrochloride infusion and oral levodopa. Fourth, FSH and LH deficiency diagnosis in females with menstrual irregularities is based on low serum FSH, LH, and estradiol levels, as well as on a 10-day medroxyprogesterone test. This is when a female is given medroxyprogesterone, a type of progesterone, for 10 days to see if that triggers menstrual bleeding. Low FSH, LH, or estradiol levels, as well as not bleeding following medroxyprogesterone, signify gonadotropin insufficiency. In males, gonadotropin insufficiency diagnosis is based on low serum testosterone, FSH, and LH levels. And fifth, serum prolactin levels are typically not measured because what's considered a normal level can vary from person to person. Now, in terms of the medications that are used to treat anterior pituitary hormone deficiencies, ACTH deficiency is usually treated with synthetic glucocorticoids like hydrocortisone. Treatment for TSH deficiency is done with thyroid hormone substitution therapy with levothyroxine. Growth hormone deficiency is treated by administering growth hormone. Gonadotropin insufficiency is treated with testosterone in males and combined estrogen and progestin therapy for females to replace the missing sex hormones. Finally, at the moment, there are currently no treatments available for prolactin deficiency. Okay, so there are a few causes of hypopituitarism to know. The first high-yield cause is Sheehan syndrome, which is hypopituitarism secondary to ischemic pituitary necrosis due to severe postpartum bleeding. Often, this causes a decrease in all hormones. Normally, labor and delivery can cause mild blood loss without any long-term complications. However, severe bleeding can decrease blood supply to the pituitary, causing ischemia and necrosis. Another factor is pregnancy-induced pituitary growth, where the gland outgrows available blood supply during pregnancy. This growth is usually the result of the estrogen surge that occurs during pregnancy, which leads to hyperplasia of lactotrophs, the cells responsible for prolactin production. Symptom-wise, the syndrome is suspected in those who just gave birth and present with failure to lactate and absent menstruation, both due to prolactin deficiency. In other cases, individuals can develop additional features of hypopituitarism, like hypothyroidism or cortisol deficiency, depending on the extent of necrosis. Diagnosis is clinical, based entirely on history of pregnancy and birth, and symptoms like galactorrhea. Although prolactin levels are usually not measured, the basal levels of the other pituitary hormones are necessary. Treatment consists of lifelong hormone substitution therapy for each individual hormone that's missing. Next, empty sella syndrome is when the pituitary gland shrinks due to atrophy or compression and the sella turcica is filled with CSF. This syndrome can occur as a primary disorder, where the cause of the atrophy is unknown, but it's commonly associated with obese women. Some high-yield secondary causes include pituitary surgery, head trauma, and idiopathic intracranial hypertension, previously known as pseudotumor cerebri, which is increased intracranial pressure without a detectable cause. Now, most individuals are asymptomatic because pituitary function is typically normal. Others can develop hypopituitarism, headaches, high blood pressure, and rarely increased intracranial pressure, cerebrospinal fluid leakage through the nose, or cerebrospinal rhinorrhea, as well as vision abnormalities. Diagnosis is made by head CT or MRI, which shows an abnormally sized or absent pituitary and accumulation of CSF in the sella turcica. Full basal serum hormone measurements might also be required, but no specific therapy is needed for an empty sella alone, but hormonal replacement might be. Next, pituitary adenomas are a group of mostly benign tumors of the pituitary gland that may or may not secrete hormones, depending on their cell of origin. A high-yield fact is that most adenomas are hormone-secreting, with prolactinomas, a tumor that secretes prolactin, accounting for more than half of the cases. However, the most common tumors that cause hypopituitarism are macroadenomas, larger than 1 centimeter, that don't secrete any hormones. They're harmful because as they grow, they can compress the normal tissue in the gland, impairing hormone secretion. These tumors can also compress the optic chiasm, which is where the optic nerves partially cross, due to its proximity to the pituitary. This causes compression symptoms like headaches and visual abnormalities like bitemporal hemianopia, or decreased vision in the outer half of both the right and left visual field, which is almost pathognomonic for pituitary tumors. Diagnosis is based on brain MRI, which identifies the tumor after a contrast substance called gadolinium is administered. For non-secreting macroadenomas, treatment is transsphenoidal resection, which is when the tumor is removed through the nose. If the surgery is successful, the pituitary function can recover completely. If not, hormonal replacement therapy might be needed. Another hypopituitarism-causing tumor is craniopharyngioma, the most common childhood supratentorial tumor. Craniopharyngioma is mostly benign, and a high-yield fact is that it originates from the remnants of the anterior pituitary embryonic tissue called Rotke's pouch. Rotke's pouch derives from the ectoderm, one of the 3 primary germ layers in the very early embryo. This tumor can also compress the pituitary gland, causing symptoms similar to an adenoma, for which it is frequently mistaken. That being said, symptoms of craniopharyngioma depend on the tumor's location. If it involves the area of the pituitary gland itself, it can cause pituitary hormone deficiency and symptoms of hypopituitarism. Also, keep in mind that if it comprises the pituitary stalk, which is the connection between the hypothalamus and the posterior pituitary, that decreases the amount of antidiuretic hormone secreted by the posterior pituitary. This leads to diabetes insipidus, with symptoms like excessive thirst and frequent urination. An additional high-yield fact is that it can also increase prolactin levels, causing galactorrhea. This is because prolactin, unlike the other hormones, is under constant inhibition by dopamine secretion from the hypothalamus. Because craniopharyngioma compresses the pituitary stalk, dopaminergic inhibition is lost, leading to uncontrolled prolactin secretion. Just like an adenoma, compression symptoms like headaches and bitemporal hemianopia are common as well. Diagnosis is based on contrast MRI showing a suprasellar cystic lesion with calcifications, and screening for pituitary hormone deficiencies, especially for cortisol deficiency due to their strong association. Sometimes a biopsy might be necessary, where the diagnosis is suggested by 3 main components, which you need to know for your exam. The solid component is represented by the actual tumor cells. There's also a cystic component, which contains a motor oil-like fluid. The fluid has a brown-yellow color and is rich in proteins, blood, and cholesterol crystals. And the third component is represented by dystrophic calcifications, which are white masses within the tumor. Treatment consists of surgical removal and, in some cases, radiotherapy. If cortisol deficiency is identified, emergency treatment with hydrocortisone should be initiated before the tumor is removed to prevent cardiovascular collapse. Next, pituitary apoplexy is a sudden hemorrhage of the pituitary gland, usually in the presence of a pituitary adenoma. It occurs when the blood vessels of the adenoma rupture and cause a hemorrhage. Subsequently, the blood collects in the interstitium and compresses the blood vessels of the pituitary itself, which leads to pituitary ischemia and loss of pituitary function. What you need to know is that the symptoms of pituitary apoplexy can include excruciating headache and visual impairment, like bitemporal hemianopia, diplopia, or double vision, and ophthalmoplegia, which is the paralysis or weakness of the eye muscles, which can also occur due to the blood buildup compressing cranial nerve 3, which innervates the eye muscles. Individuals might also have symptoms like hypopituitarism, especially signs of cortisol deficiency, like vascular collapse, shock, and mental status changes ranging from confusion to coma. Diagnosis is based on a brain MRI, where the hemorrhage looks bright white compared to the general gray shade of the central nervous system, and the pituitary is usually enlarged. Hormone deficiency screening is also mandatory. Just as in craniopharyngioma, if cortisol deficiency is detected, treatment with hydrocortisone should be initiated immediately to prevent life-threatening cardiovascular collapse. Once the individual is stable, transphonoidal surgery can be attempted to remove the mass and relieve compression symptoms. Hypopituitarism following apoplexy is usually permanent and global, meaning all hormones are deficient. So, individuals usually require lifelong hormone substitution therapy. Finally, hypopituitarism can occur following head surgery and trauma and radiation, where presentation depends on the cause and on which hormone is deficient. Diagnosis is based on imaging, like CT and MRI, and on hormone deficiency screening. Management depends on the cause and whether or not there are symptoms of hypopituitarism. In an acute setting, if there are signs of cortisol deficiency, hydrocortisone should be initiated immediately. Alright, as a quick recap. With hypopituitarism, there's a deficiency in at least one anterior pituitary hormone and, more rarely, posterior pituitary hormones. Symptoms depend on which hormone is missing, and diagnosis is based on basal serum measurements, or dynamic testing, as well as imaging studies like CT or MRI. One cause of hypopituitarism is Sheehan syndrome, which occurs in women following delivery with heavy blood loss. In empty sella syndrome, the pituitary is atrophied, and the sella turcica is filled with CSF. It may occur as a primary disorder, or it can be due to pituitary surgery, head trauma, or idiopathic intracranial hypertension. Macroadenomas and craniopharyngiomas are benign tumors that cause compression symptoms like headaches and bitemporal hemianopia, alongside possible hypopituitarism if the gland is damaged. Finally, pituitary apoplexy is when a pituitary tumor hemorrhages itself. Management depends on eliminating the cause, like surgical removal of the tumor. If there's permanent damage to the gland, lifelong hormone therapy might be needed, depending on which hormone is deficient. And finally, back to our cases. Regina presented with symptoms like depression, cold intolerance, fatigue, bradycardia, and delayed relaxation of reflexes, which are suggestive of hypothyroidism. And this diagnosis was confirmed by the low serum T4 levels. This decrease is likely due to hypopituitarism, secondary to Sheehan syndrome, which can be diagnosed clinically based on her history of an inability to lactate and amenorrhea following a postpartum hemorrhage. On the other hand, Alexander presented with loss of sex drive, erectile dysfunction, and significant weight gain. These can be caused by decreased FSH, LH, and testosterone levels. He also presented with bitemporal hemianopia, and together with his other symptoms, we can suspect a pituitary tumor, most likely an adenoma, which causes gonadotropin insufficiency and, subsequently, hypopituitarism. The next step, in Alexander's case, would be brain imaging to confirm the tumor's presence and location. Surgical resection of the tumor might be required.
With hypopituitarism, hypo means under, and pituitarism refers to the pituitary gland, which normally secretes various endocrine hormones. So hypopituitarism is the underproduction of hormones released by the pituitary gland, and the symptoms depend on which hormones are actually undersecreted. If all of the pituitary hormones are affected, it's called panhypopituitarism. Now, the pituitary is a pea-sized gland, hanging by a stalk from the base of the brain. It sits just behind the eyes near the optic chiasm, which is where the optic nerves cross, and the gland rests in a super small depression of the skull known as the sella turcica. The pituitary gland produces and secretes hormones when it receives signals from another part of the brain called the hypothalamus. Together they form the hypothalamic pituitary axis, which regulates the release of all the major endocrine hormones. The pituitary itself has two distinct parts, the anterior pituitary and the posterior pituitary. The anterior pituitary, which is in the front of the pituitary gland, has a few different types of cells, each of which secretes a different hormone. The largest group of cells are the somatotropes, which secrete growth hormone, which goes on to promote tissue and organ growth. The second largest cell group are the corticotrophs, which secrete adrenocorticotropic hormone, or ACTH, which stimulates the adrenal glands to secrete cortisol, a hormone that controls the stress response, blood pressure, and metabolic regulation. A smaller cell group are the lactotrophs, which secrete prolactin. Prolactin stimulates breast milk production, and also inhibits ovulation, which is when an egg cell is released from the ovary, and inhibits spermatogenesis, which is the development of sperm cells. There are also thyrotrophs, which are cells that secrete thyroid-stimulating hormone, or TSH, that stimulates the thyroid gland. And finally, there are gonadotrophs, which secrete two gonadotropic hormones, luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH, both of which go on to stimulate the ovaries or testes. The posterior pituitary, which is the back of the pituitary gland, releases the antidiuretic hormone, or ADH, which is made by the hypothalamus. ADH acts on the kidneys to decrease the amount of water lost in the urine. The posterior pituitary also produces oxytocin, which is responsible for uterine contractions during labor and milk letdown during breastfeeding. Hypopituitarism can be the result of compression, tissue ischemia or infarction, or iatrogenic or medically induced injuries. Let's start with compression. Since the pituitary exists within the super confined space of the sella turcica, it's super sensitive to changes in that space. Even the slightest amount of compression can interfere with the pituitary's hormone production. In adults, the most common cause of compression is a pituitary tumor, or adenoma, and in children, the tumor is usually a craniopharyngioma. Craniophryngiomas are pituitary tumors that develop from the cells of Rathke's pouch, which is a structure that normally develops into the anterior pituitary gland during fetal development. In addition to solid tissue compressing the pituitary gland, liquid-like cerebrospinal fluid can also have the same effect. For example, in empty sella syndrome, the sella becomes filled with cerebrospinal fluid, and it can make the pituitary shrink or flatten and ultimately become non-functional. Hypopituitarism can also be due to pituitary apoplexy, which is a disorder where there's either severe bleeding, like with hemorrhage, or a loss of blood flow to the pituitary gland, known as infarction. The more common way is hemorrhage, and the hemorrhage is usually caused by pituitary adenoma, which is a benign tumor of the anterior pituitary gland. Larger tumors demand more blood, and increased blood flow means increased pressures in the vessels. which can eventually cause them to rupture and bleed. The second and less common way that hypopituitarism caused by pituitary apoplexy can develop is when there's infarction of the pituitary gland. An example would be Sheehan syndrome, which is commonly associated with pregnant women. During pregnancy, there's an increased demand for blood by the pituitary cells, and coupled with excessive blood loss during childbirth, it leaves pituitary cells without adequate blood flow, and they start to die. If the blood flow isn't restored soon enough, more and more tissue dies, and over time the pituitary gland shrinks, becomes scarred, and can no longer effectively secrete hormones. Finally, there are iatrogenic causes of hypopituitarism, like when there's unintentional damage to the pituitary gland during radiation therapy or neurosurgery. Symptoms of hypopituitarism can vary a ton, depending on which hormones are depleted. In general, luteinizing hormone, follicle-stimulating hormone, and growth hormone are lost before thyroid-stimulating hormone and adrenocorticotropic hormone. So if we go through these in order, first you have hyposecretion of follicle-stimulating and luteinizing hormone, together known as gonadotropins. And these can cause problems for men and women. Women might experience oligomenorrhea, which is a decrease in their menstrual bleeding, or amenorrhea, which is a complete absence of menstrual bleeding, and possible infertility. Men might experience loss of pubic hair and a reduction in muscle mass. Both men and women commonly complain of a diminished libido. Loss of gonadotropins is also seen in Sheehan syndrome, resulting in similar symptoms like absent menstruation, but the loss of prolactin also causes problems with postpartum lactation. Moving on, a lack of adrenocorticotropic hormone causes adrenal insufficiency, or a lack of cortisol production by the adrenal glands, and that leads to weight loss, delayed puberty, and low blood sugar and sodium levels. Growth hormone deficiency results in a failure to grow in children, delayed puberty in adolescents, and decreased lean body mass and low bone density in adults. Hypopituitarism can also cause hypothyroidism due to the diminished production of thyroid-stimulating hormone with classic symptoms like weight gain, constipation, hair loss, and low blood pressure. Finally, in addition to all the endocrine abnormalities seen in hypopituitarism, if there's a tumor or fluid buildup, it can cause local symptoms like increased intracranial pressures and headaches. The pituitary gland is also close to the optic chiasm, which again is where the optic nerves cross. So any extra pressure in the area will press on these nerves and lead to visual field defects, like bitemporal hemianopsia, where a person has partial blindness in the lateral fields of both eyes. Diagnosis of hypopituitarism is usually done by first assessing baseline levels of hormones in the morning, which accurately measure all the pituitary hormones except for growth hormone and adrenocorticotropic hormone, because those hormone levels are more variable throughout the day. Next, it's helpful to see how hormone levels change in response to a substance that should stimulate hormone release. For example, administering insulin should cause a drop in blood sugar, which in turn stimulates the release of growth hormone and adrenocorticotropic hormone from the anterior pituitary. If these hormone levels stay low despite the stimulatory effects of insulin, it might indicate hypopituitarism. Finally, MRI scans can help to look for possible causes of hypopituitarism, like tumors and hemorrhage. Treatment of hypopituitarism is based on correcting the underlying cause. In the case of an adenoma, surgery can be performed to remove the tumor. Hormone replacement therapy might be needed if the pituitary damage is severe. Alright, as a quick recap. Hypopituitarism is the undersecretion of any of the hormones normally produced by the pituitary gland located at the base of the brain. It's caused by tumors, pituitary hemorrhage or infarction, and by accidental damage during radiation or surgery. Lastly, it can be treated by hormone replacement therapy or tumor removal.
Constitutional growth delay is a normal variation of development, where there's a temporary delay in growth that occurs during early childhood and puberty. You can think of it as a slowed rate of maturation, which happens normally in some people. It's the most common cause of short stature and pubertal delay in children and adolescents, but by adulthood, people with constitutional growth delay generally end up with normal adult heights. Generally speaking, there are two hormonal systems that control growth: the growth hormone axis and the hypothalamic pituitary gonadal axis. The growth hormone axis starts with the hypothalamus, which is at the base of the brain. The hypothalamus secretes growth hormone releasing hormone, and that then stimulates the anterior pituitary gland to produce growth hormone. Now, growth hormone affects a lot of tissues, but in particular it makes the body retain nitrogen, which leads to more muscle growth. Osteoblasts also get stimulated, which causes bones to thicken. Growth hormone also stimulates certain tissues like the liver, skeletal muscles, bones, and kidneys to produce something called somatomedin C, also called insulin-like growth factor 1. Insulin-like growth factor 1 has a lot of effects on cells, where it promotes cellular metabolism, prevents cell death, and helps cells to divide and differentiate throughout the body. It's also the key hormone that stimulates the growth in length of long bones. Now, when it comes to sexual maturation, that's under the control of the hypothalamic pituitary gonadal axis. This axis also starts with the hypothalamus, which releases something called gonadotropin releasing hormone, or GnRH. And GnRH then stimulates the anterior pituitary to produce gonadotropin hormones, which are luteinizing hormone, or LH, and follicle stimulating hormone, or FSH. LH and FSH then stimulate the gonads, which are the ovaries in females and the testes in males, and these then produce sex-specific hormones, which are estrogen and progesterone in females and testosterone in males. Now, the amount of hormone that gets produced by this axis varies over a person's lifetime, and that affects the development of sex organs as well as the appearance of secondary sex characteristics. During puberty, there's an increase in GnRH production, and that leads to increased levels of FSH and LH, and then that triggers the onset of sexual maturity. The stages of sexual maturity that a person goes through are referred to as the Tanner scale. The Tanner scale centres on two independent criteria. Firstly is the appearance of pubic hair in both sexes, and secondly, in men it's the increase in testicular volume and penile size and length, and in women it's breast development. There are 5 stages. In stage 1, the prepubertal stage, no pubic hair is present in either sex. Males have a small penis and testes, and females have a flat chest. In stage 2, pubic hair appears, and there's a measurable enlargement of the testes, and breast buds appear. In stage 3, pubic hair becomes coarser, the penis begins to enlarge in both size and length, and breast mounds form. In stage 4, pubic hair begins to cover the pubic area, and the penis begins to widen, and breast enlargement continues to form something called a mound-on-mound contour. And finally, in stage 5, pubic hair extends to the inner thigh, the penis and testes have enlarged to adult size, and the breasts take on adult contour. Now, importantly, constitutional growth delay is not a disorder, but just a normal variation in growth rate. Growth charts are often used to track the development of children, and they usually have age on the x-axis, which is the horizontal axis, and head circumference, weight, or height on the y-axis, which is the vertical axis. What happens is the children typically have a normal height and weight at birth, but during the first few years of their life, their growth rate declines. Children with constitutional growth delay may fall to right around the 2nd percentile, but their growth rate picks up again and matches that of their peers by around age 4. At that point, their growth rate is parallel to other children, which means that they're growing a similar number of centimetres or inches per year, but overall their height still lags behind other children their age. When other children hit puberty, children with constitutional growth delay are still a bit behind in terms of growth and sexual development. But then they typically have a growth spurt later than normal, and in this time they can catch up with their peers, both in terms of height and sexual development, ultimately reaching a normal adult height. The cause of constitutional growth delay is not well understood. It may be due to a transient growth hormone deficiency, or to a pituitary gland that doesn't start producing hormones on time, like snoozing through an alarm. However, there does seem to be an inherited element, meaning that individuals with constitutional growth delay are more likely to have children with a constitutional growth delay as well. Aside from a delay in growth and a delay in developing sexual characteristics, constitutional growth delay doesn't come along with any other symptoms, and people usually have a normal adult height. Unfortunately, some individuals can feel a lot of psychological stress from a constitutional growth delay, because they may feel like they don't fit in with their peers, and it can trigger feelings of depression and anxiety. When it comes to diagnosis, constitutional growth delay is the most common cause of short stature, which is having a height that's below the 2.3 percentile. It's also helpful to get a bone age, which is the degree of maturation of a child's bones, usually determined based on an X-ray of the left hand. In constitutional growth delay, the bone age is at least a year less than the child's actual age. Since constitutional growth delay is a normal variation of growth, it's critical to distinguish it from possible causes of growth problems. Constitutional growth delay can be distinguished from hypothyroidism because there are normal levels of thyroid hormones. It can also be distinguished from Cushing's syndrome because there should be a normal 24-hour urine cortisol level. Finally, if there's a tumour compressing the pituitary gland causing growth hormone suppression, this could be diagnosed by a stimulated growth hormone test, where a synthetic version of growth hormone releasing hormone is given to a person to see if growth hormone is released. In most cases of constitutional growth delay, the most important thing to do is to reassure individuals that the delay is only temporary and that they will still reach their adult height and sexual development, just a bit later than their peers. However, in rare cases, a short course of sex steroids can be used to speed up sexual development. Okay, so as a quick recap, constitutional growth delay causes an overall delay in growth during childhood and pubertal development, but ultimately results in a normal adult height. The main problem with constitutional growth delay is that it's associated with psychological distress, which can be treated with a short course of sex steroids.
Growth hormone deficiency is a condition that happens when the pituitary gland fails to release enough growth hormone. Growth hormone, also known as somatotropin, helps promote overall growth of the body, muscle mass development, protein synthesis, and carbohydrate and lipid metabolism. So a deficiency in growth hormone, which can happen in kids and adults, results in problems in all of these areas. Growth hormones released by the pituitary, which is a pea-sized gland that's connected by a stalk to a part of the brain called the hypothalamus. The hypothalamus secretes growth hormone releasing hormone, which travels through a network of capillaries called the hypophyseal portal system. Growth hormone releasing hormone eventually reaches the anterior pituitary and triggers it to secrete growth hormone. Growth hormone then travels via the blood to various target tissues in the body to stimulate growth. This is called the hypothalamic pituitary axis. Normally, growth hormone's released in a pulsatile manner throughout the day, and peaks 1 hour after you fall asleep, but it's also secreted in response to various forms of internal and external stimuli. For example, the hypothalamus senses when there's hypoglycemia, or low blood sugar, and in response it secretes growth hormone releasing hormone. Exercise causes the adrenal glands to secrete epinephrine, and that stimulates the hypothalamus to react in the same way. Estrogen and testosterone, which are produced in high levels during puberty, stimulate the hypothalamus to release growth hormone releasing hormone as well. The hypothalamic pituitary axis, though, is also regulated by 3 negative feedback loops, which can prevent the release of additional growth hormone. First off, high levels of growth hormone and growth hormone releasing hormone in the blood can signal the hypothalamus to stop secreting more growth hormone releasing hormone. Second, it also stimulates the hypothalamus to produce somatostatin, which is a hormone that directly inhibits the anterior pituitary from releasing growth hormone. Third, growth hormone secretion from the anterior pituitary is inhibited by a somatometin called insulin-like growth factor 1, which also stimulates somatostatin release from the pituitary. Somatometins are produced in the liver and have many of the same growth-promoting effects on target tissues as growth hormone does. It mediates these effects by binding to insulin-like growth factor 1 receptors as well as insulin receptors, which are present on almost all tissue types. Growth hormone can stimulate growth in most organs in the body. In the muscles, it stimulates amino acid uptake into the muscle cells, which helps with protein production and muscle growth. Similarly, growth hormone stimulates the activity of osteoblasts in the bones and chondrocytes in the cartilage, which helps boost growth, particularly during the growth spurts of puberty. Growth hormone also has a ton of metabolic functions. In adipose tissue, it causes lipolysis, which is the breakdown of fats, and gluconeogenesis in the liver, which is the production of glucose. To increase glucose levels, growth hormone causes insulin resistance, which decreases insulin's ability to move glucose into the cells. Growth hormone also triggers the steady release of insulin-like growth factor from the liver, and once released into the bloodstream, insulin-like growth factor has many of the same effects as growth hormone. Most cases of growth hormone deficiency have no identifiable cause, but sometimes there is a specific genetic or physiologic cause. One genetic cause is a mutation in the receptor for growth hormone releasing hormone, leaving the growth hormone releasing hormone with nowhere to bind. More broadly, there are genetic syndromes associated with growth hormone deficiency. These include Prader-Willi syndrome, which is a defect in the paternal copy of chromosome 15, and Turner syndrome, where a female is missing one or two of her X chromosomes. There are also acquired causes of growth hormone deficiency, like brain trauma, infections, and radiation therapy, all of which can cause damage to the hypothalamus and the pituitary gland. The most common cause of acquired growth hormone deficiency is a pituitary tumor, which can cause compression of the gland. This tumor-induced compression cuts off the blood supply to the pituitary gland and can prevent the release of a number of other pituitary hormones, like sex hormones, a condition called hypopituitarism. Since sex hormones normally stimulate the release of growth hormones, conditions like hypopituitarism and delayed puberty, where there's a deficiency in sex hormones, can also lead to growth hormone deficiency. Growth hormone deficiency can cause a variety of symptoms, and vary in children and adults. Decreased growth hormone results in low blood glucose levels, and that can lead to severe hypoglycemia, especially in infants. In children, chronic growth hormone deficiency can cause an understimulation of osteoblasts, resulting in a short stature, and in severe cases might cause dwarfism. Sometimes that understimulation of osteoblasts means that the growth plates of the bones don't fully fuse, and therefore bone growth of a child with growth hormone deficiency will be significantly slower than the average child of the same age. This is referred to as delayed bone age. Additionally, decreased muscle development can cause children to have delayed developmental milestones in gross motor function, like standing, walking, and jumping. Delayed milestones, delayed puberty, and short stature are the most common complaints of parents with children that have a deficiency of growth hormone. In adults, decreased growth hormone can cause muscles to weaken over time and a lower bone density with bones that are prone to fractures. Psychological symptoms include poor memory, social withdrawal, and depression. Diagnosis typically starts by measuring growth hormone in the blood, but because growth hormone levels fluctuate throughout the day, the testing is usually done after giving a person a stimulatory agent like epinephrine or insulin. It's also helpful to measure insulin-like growth factor levels, which are relatively stable throughout the day. In children, X-rays of the hand can also reveal a delayed bone age. Growth hormone deficiency is treated by growth hormone therapy, which usually involves regular injection of recombinant human growth hormone. Alright, as a quick recap. Growth hormones an endocrine hormone secreted by the anterior pituitary, and has a variety of functions including stimulating growth of all tissue, especially muscle and bone, and it also promotes gluconeogenesis and protein and fat breakdown. Most of these functions are mediated by the somatometin called insulin-like growth factor 1. In children, growth hormone deficiency manifests as a failure to grow and is associated with delayed puberty, whereas adults experience more generalized symptoms. With hypoprolactinemia, hypo means below, prolactin refers to the hormone produced by the pituitary gland, and emia refers to the blood. So hypoprolactinemia means lower than normal prolactin levels in the blood. Normally at the base of the brain there's a small pea-sized gland called the pituitary gland. The anterior pituitary, which is the front of the pituitary gland, has a number of different cells, each of which secrete a different hormone. One group, the lactotroph cells, secrete prolactin. In men, prolactin decreases testosterone production. In women, during pregnancy, elevated levels of estrogen stimulate the lactotroph cells to produce large amounts of prolactin, which stimulate alveolar cells in the breasts. In response to prolactin, the alveolar cells divide and enlarge. And once a baby is born, lactogenesis starts, which means that milk is produced. Apart from milk production, high levels of prolactin also inhibit the release of gonadotropin-releasing hormone from the hypothalamus, which results in decreased luteinizing and follicle-stimulating hormone levels, which in turn decreases estrogen levels. In women, this can stop ovulation and menstruation, which is why women typically don't have a menstrual period while breastfeeding. In women that aren't pregnant or breastfeeding, as well as in men, prolactin levels are usually kept in check by the hypothalamus in two ways. The first way is the most important, and it's when the hypothalamus secretes a constant stream of dopamine, which in this setting is also called prolactin inhibiting factor. Dopamine binds to specific receptors on the lactotroph cells and inhibit the release of prolactin. The second way is less significant, and it's when the hypothalamus secretes thyrotropin releasing hormone, also called prolactin releasing hormone, which can stimulate prolactin release. If the level of prolactin rises for any reason, then it signals the hypothalamus to release more dopamine, eventually decreasing its own production, a process called negative feedback or feedback inhibition. The most common cause of hypoprolactinemia is Sheehan syndrome, a disorder where lactotroph cells die, in a woman that's recently given birth and has postpartum hemorrhage, or excessive blood loss during delivery. That happens because the lactotroph cells have an increased demand for blood, and the postpartum hemorrhage results in a decreased supply of blood, and that leads to ischemia and necrosis. Another cause of hypoprolactinemia is taking medications containing dopamine, as well as dopamine agonists like bromocriptine, which inhibits prolactin release from lactotroph cells. Another cause is a tumor in the pituitary gland or hypothalamus, which puts pressure on the nearby lactotroph cells and interferes with their ability to produce prolactin. That happens in part because the tumor creates local inflammation that can damage the lactotroph cells. Hypoprolactinemia generally only causes symptoms in breastfeeding women, who can have agalactorrhea, which is a decrease in breast milk production. In women that aren't breastfeeding, as well as in men, hypoprolactinemia usually doesn't cause any symptoms. The diagnosis of hypoprolactinemia can be made when there are decreased levels of prolactin in the blood, particularly if the levels of prolactin are low in spite of receiving thyrotropin-releasing hormone. An MRI can help confirm the Sheehan syndrome or the presence of a pituitary or hypothalamic tumor. Treatment's usually reserved for women who want to breastfeed. Dopamine antagonists can be used to oppose the action of dopamine, and that removes the inhibition on the lactotroph cells. If there's a tumor, though, surgery might be needed. Alright, as a quick recap, hypoprolactinemia, or low prolactin levels in the blood, is most often caused by Sheehan syndrome, where lactotroph cells die in women who have postpartum hemorrhage. These women can develop agalactorrhea and can be treated with dopamine antagonists. With pituitary apoplexy, pituitary refers to the tiny gland at the base of the brain, and apoplexy refers to bleeding or loss of blood flow to an organ. So, pituitary apoplexy is a disorder where there's either severe bleeding or loss of blood flow to the pituitary gland, and this results in cell death and sudden loss of function. Normally, the pituitary is a pea-sized gland, hanging by a stalk from the base of the brain. It sits just behind the eyes near the optic chiasm, which is where the optic nerves cross. The anterior pituitary, which is the front of the pituitary gland, contains a few different types of cells, each of which secretes a different hormone. The largest group of cells are the somatotropes, which secrete growth hormone, or GH for short, which goes on to promote tissue and organ growth. The second largest cell group are the corticotrophs, which secrete adrenocorticotropic hormone, or ACTH, which stimulates the adrenal glands to secrete cortisol, a hormone that controls the stress response, blood pressure, and metabolic regulation. A smaller cell group are the lactotrophs, which secrete prolactin. Prolactin stimulates breast milk production, and also inhibits ovulation, which is when an egg cell is released from the ovary, and inhibits spermatogenesis, which is the development of sperm cells. There are also thyrotrophs, which are cells that secrete thyroid-stimulating hormone, or TSH, which goes on to stimulate the thyroid gland. And finally, there are also gonadotrophs, which secrete two gonadotropic hormones, luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH, both of which go on to stimulate the ovaries or testes. Now, the posterior pituitary, which is the back of the pituitary gland, releases the antidiuretic hormone, or ADH, which is made by a part of the brain called the hypothalamus. ADH acts on the kidneys to decrease the amount of water lost in the urine, or essentially retain water. The pituitary gland gets blood from two arteries, and the first is the superior hypophyseal artery, which forms a part of the hypophyseal portal system, which is a web of capillaries linking the hypothalamus to the anterior pituitary. The second artery is the inferior hypophyseal artery, and that one supplies the posterior pituitary. After delivering oxygen, the blood collects in small pituitary veins and eventually drains into the nearby venous sinuses, or spaces of the brain. Pituitary apoplexy can develop as a result of hemorrhage or infarction. The more common way is a hemorrhage, which is profuse bleeding into the pituitary gland. The hemorrhage is most often due to a pituitary adenoma, which is a benign tumor of the anterior pituitary gland. Larger tumors demand more blood, and increased blood flow means increased pressure in the vessels, which can eventually cause them to rupture. That blood collects in the interstitium, or space between the cells, which makes the pituitary gland swell up. An enlarged pituitary gland can compress surrounding structures like the meninges, which is the protective layer overlying the brain, and that typically causes pain when it's stretched. Also, an enlarged pituitary gland can compress the optic nerves as they cross at the optic chiasm. This can affect a person's ability to view things that are in the temporal or outermost portion of the visual field in both eyes, also called bitemporal hemianopia. Another name for this is tunnel vision, because the center of your vision is clear, but everything in the periphery is dark, which is kind of like looking through a tunnel. Finally, the pool of blood can also put pressure on nearby blood vessels and pinch them shut, leaving the pituitary cells without oxygen. Other causes of pituitary hemorrhage include brain surgery and trauma to the head. The second and less common way that pituitary apoplexy can develop is when there's infarction of the pituitary gland. An example would be Sheehan syndrome, which is commonly associated with pregnant women. During pregnancy, there's an increased demand for blood by the pituitary cells, and coupled with excessive blood loss during childbirth, it leaves the pituitary cells without adequate blood flow, and they start to die. If the blood flow isn't restored soon enough, more and more tissue dies, and over time the pituitary gland shrinks and becomes scarred. Regardless of the underlying cause, pituitary apoplexy results in hypopituitarism, which is a deficiency of pituitary hormones. Immediate symptoms of pituitary apoplexy are usually due to the lack of adrenocorticotropic hormone, as well as the deficiency of cortisol, which causes symptoms like hypoglycemia or low blood glucose, low blood pressure, and a loss of consciousness, which is a medical emergency. Symptoms caused by deficiency of the other hormones, though, have a more gradual onset. Deficiency of thyroid hormone causes weight gain and cold intolerance. Deficiency of gonadotropin hormones can cause menstrual problems, low libido, and infertility. Low growth hormone can lead to fatigue and loss of muscle mass. Finally, low prolactin levels generally only cause symptoms in breastfeeding women, who can have agalactorrhea, which is a decrease in breast milk production. Diagnosis of pituitary apoplexy involves imaging using a CT scan or MRI, which shows an enlarged pituitary gland with a hyperintense blood-filled center. Blood tests can also be done to look for low levels of adrenocorticotropic hormone, thyroid-stimulating hormone, luteinizing hormone, follicle-stimulating hormone, growth hormone, and prolactin. Treatment for pituitary apoplexy requires emergency replacement of glucocorticoids to help maintain a person's blood pressure and glucose levels. Typically, the person needs replacement of the deficient hormones for the rest of their life. Pituitary tumors with apoplexy might require transsphenoidal surgical resection, which is when the tumor is removed through the nose and sphenoidal sinus. Alright, as a quick recap. In pituitary apoplexy, cells in the pituitary gland die due to a hemorrhage, where the pituitary swells, or an infarction, where the pituitary shrinks. Both cause hypopituitarism, but a swelling pituitary can also cause a sudden headache, nausea, vomiting, and finally loss of consciousness.
With Sheehan syndrome, also sometimes called postpartum pituitary gland necrosis, postpartum refers to the time after a mother gives birth to an infant. Pituitary gland refers to a tiny gland that is at the base of the brain, and necrosis refers to death. So postpartum pituitary gland necrosis is a disorder where the cells in a pituitary gland of a new mother start to die, most commonly because of excess blood loss during childbirth that leaves those cells without adequate blood flow. It's a rare type of pituitary apoplexy. During pregnancy, a group of cells in the pituitary gland called lactotrophs start to increase in size and number. These lactotrophs secrete the hormone prolactin, and the increased levels of prolactin prepares the mammary glands to produce milk. Even though there are more lactotrophs that are larger and more metabolically active, the blood supply of the pituitary gland remains the same, so there is this increased blood demand without an increase in supply, making the lactotrophs hypoperfused. In other words, the lactotrophs are just barely getting enough oxygenated blood, and they will become ischemic and die if blood flow is reduced further. Since there are more metabolically active lactotrophs around, they take up a larger proportion of the blood that supplies the pituitary gland. This increases the risk of ischemia in the other cells of the pituitary gland as well. During the delivery of an infant, some mothers can experience excessive blood loss, which is called postpartum hemorrhage. Postpartum hemorrhage is generally defined as losing more than 500 milliliters of blood after a vaginal delivery or more than 1,000 milliliters of blood after a cesarean section delivery. When this happens, there's less blood flowing to the cells of the pituitary gland. Coupled with the increased demand for blood by the lactotrophs, the pituitary cells no longer receive enough oxygen to survive, resulting in ischemic necrosis. If blood flow isn't restored soon, more and more cells in the pituitary die, and the pituitary gland progressively shrinks, becoming scarred, and stops producing enough of one or more hormones. In severe cases, severe destruction and scarring can lead to an empty sella turcica, which is when the pituitary gland shrinks and flattens into the skull. Increased cell death within the pituitary also means that a number of hormone levels start to fall. This includes growth hormone, adrenocorticotropic hormone, which acts on the adrenal gland, thyroid-stimulating hormone, which acts on the thyroid and gonadotropins, luteinizing hormone, and follicle-stimulating hormone, which acts on the ovaries. Sheehan syndrome results in hypopituitarism, a deficiency of the pituitary gland, and the symptoms are all related to a decrease in the various pituitary hormones. A classic early symptom of Sheehan syndrome is agalactorrhea, which is not being able to make as much breast milk or none at all because of a lack of prolactin. Later symptoms include amenorrhea, an absence of normal menstruation cycle, even after a period of lactation, which is due to a lack of luteinizing hormone and follicle-stimulating hormone. Sheehan syndrome can also cause hypothyroidism, which can cause low blood pressure, cold intolerance, and weight gain. It can also lead to low adrenocorticotropic hormone levels and a subsequent adrenal gland insufficiency, caused by a decrease in sodium and blood glucose levels. Low growth hormone can lead to fatigue and loss of muscle mass. In some women, the damage to the pituitary is relatively mild, so they have relatively normal levels of prolactin, and they don't have troubles with breastfeeding. Instead, they might notice the other symptoms months to years after their delivery. Sheehan syndrome is typically diagnosed by measuring the pituitary hormone levels, which usually fall depending on the severity of the ischemic necrosis. In addition, MRI and CT scans can show a ring enhancement or halo around a partially or completely empty sella turcica, called the pituitary ring sign. Sheehan syndrome can be treated by replacing the deficient hormones, and typically they're needed for a person's entire life. Alright, as a quick recap, in pregnancy, the pituitary cells are getting just enough blood to survive because the lactotrophs increase in size and number, taking up more blood than usual. In Sheehan syndrome, postpartum hemorrhage causes lactotrophs and other cells of the pituitary to die, resulting in low levels of prolactin, growth hormone, thyroid-stimulating hormone, adrenocorticotropic hormone, luteinizing hormone, and follicle-stimulating hormone. An early symptom is agalactorrhea, whereas late symptoms include amenorrhea, low blood pressure, low blood sodium, low blood glucose levels, as well as fatigue and muscle loss. Hi everybody, Kyle here. You might have noticed that this video was actually narrated by me, and that's because Tanner decided to go on vacation for 2 weeks. So that means the rest of us are having to pick up the slack without him. Anyways, today's video was written by Janavi, and it was edited by Rishi and myself. I narrated the video, as well as our amazing illustrator Brittany made the visuals for it, and Ifan, our amazing video editor, also did the editing for the video. So thanks so much, and we'll see you next time.
With diabetes insipidus, diabetes means an increased passing of urine, and insipidus means tasteless. So diabetes insipidus is a condition characterized by the production of large quantities of dilute and tasteless urine. The tasteless urine of diabetes insipidus distinguishes it from diabetes mellitus, which describes sweet-tasting urine. And to answer your question, yes, urine was really tasted at one point in time to make that distinction. Now, in the brain, there's a region called the hypothalamus. Inside the hypothalamus are osmoreceptors, which can sense the osmolality of the blood, or basically how concentrated it is. Osmolality is the concentration of dissolved particles in the blood plasma, or the liquid portion of blood. And there are a number of dissolved particles in the blood plasma, but the major ones are glucose, sodium, and blood urea nitrogen. And a normal osmolality is between 285 and 295 milliosmoles per kilogram. During periods of dehydration, there's an increase in concentration of these particles in the blood, and so osmolality increases. The osmoreceptors in the hypothalamus detect that increased osmolality, and that triggers the sensation of thirst, which tells us to drink more water. The water then gets absorbed and dilutes the blood, bringing the osmolality back to normal. In addition to osmoreceptors, the hypothalamus has a cluster of neurons that are found in a specific spot called the supraoptic nucleus. These neurons produce a hormone called antidiuretic hormone, or ADH. ADH is also called vasopressin because it causes smooth muscle around the blood vessels to contract, which increases blood resistance and raises the blood pressure. When the osmoreceptors detect high osmolality, they signal the supraoptic nucleus to send ADH down the supraoptico-hypophyseal tract, which runs through the infundibulum or pituitary stalk and into the posterior pituitary gland, where it's then released into the blood. ADH travels to the kidneys, specifically to the distal convoluted tubule and the collecting ducts of the nephrons, and binds to a receptor called vasopressin receptor 2, or AVPR2. When AVPR2 is bound, proteins called aquaporins, which usually sit in vesicles inside the cells of the distal convoluted tubule and collecting ducts, start to embed themselves in the apical surface of the cells, which is the side that faces the lumen of the tubule. These aquaporins ultimately allow water, and only water, to travel out of the lumen of the tubule and into the cells lining the nephron, and ultimately back into the blood. Just like drinking more water, this dilutes the blood, and returns plasma osmolality to a normal level. This reabsorption process, though, also decides how much water leaves the body as urine, and how concentrated that urine is, which is one of the things that keeps a normal urine osmolality between 300 and 900 milliosmoles per kilogram. Diabetes insipidus is when the kidneys reabsorb too little water from the lumen of the tubule, and this causes the body to produce unusually large quantities of urine, which is called polyuria. Since there's less water in the blood, plasma osmolality increases, and that triggers thirst and causes an individual to drink a lot, which is called polydipsia. There are 4 types of diabetes insipidus, each with its own underlying cause. The first type is central diabetes insipidus, which is when there's a problem in the hypothalamus or pituitary gland preventing ADH production or release. As a result, there's insufficient ADH in the blood, and that means that there's less vasoconstriction, and that there aren't enough aquaporins in the kidneys. Central diabetes insipidus is often caused by damage to the hypothalamus, osmoreceptors, the supraoptic nucleus, or the supraoptico-hypophyseal tract. But in other cases, the exact cause is hard to identify. The second type is nephrogenic diabetes insipidus, which is when there's a problem with the kidneys themselves, which makes them unresponsive to ADH. That can happen due to a genetic defect, which can lead to abnormal vasopressin receptors or aquaporin proteins that are unresponsive to ADH. In addition, there are medications like lithium that can decrease the production of aquaporin proteins in the collecting duct. Finally, there are kidney disorders like polycystic kidney disease that can cause diabetes insipidus. The third type is gestational diabetes insipidus, which happens when the placenta of a pregnant woman releases an enzyme called vasopressinase that breaks down vasopressin or ADH. As a result, ADH might still be produced and released as normal, but it doesn't get to exert its full effect on the blood vessels or kidneys. In women with gestational diabetes insipidus, vasopressinase is produced starting in week 8 of pregnancy, and peaks in the 3rd trimester. As a result, the symptoms typically worsen during the course of the pregnancy right up until birth when the placenta is removed, but can continue for up to 2 months after birth due to residual vasopressinase. The fourth type is dipsogenic diabetes insipidus, or psychogenic polydipsia, which is caused by drinking way too much water. Dipsogenic diabetes insipidus is often psychological in nature, like in individuals with schizophrenia who might compulsively drink water. In contrast to the other 3 types of diabetes insipidus, dipsogenic diabetes insipidus leads to a decrease in blood osmolality. The hypothalamus decreases the release of ADH as a normal physiological response, and the kidneys try to excrete water, which leads to polyuria, or excess urination. The symptoms of diabetes insipidus are polyuria and polydipsia. A person with diabetes insipidus typically makes over 3 liters of dilute urine each day. Diabetes insipidus can quickly lead to dehydration and low blood pressure. The increase in plasma osmolality can result in fatigue, nausea, poor concentration, or confusion. The diagnosis of diabetes insipidus might start with a blood osmolality test, which would show an increased blood osmolality of above 295 milliosmoles per kilogram in central, gestational, and nephrogenic diabetes insipidus. If blood osmolality is in the usual range but an individual is still experiencing both polyuria and polydipsia, then it might be due to dipsogenic diabetes insipidus, which would be confirmed by finding out if the person is drinking massive amounts of water. In addition, a water deprivation test can be done. This is where an individual doesn't drink water for a few hours. Then hourly measurements of urine volume and osmolality are done. In a person with diabetes insipidus, urine osmolality will usually stay below 300 milliosmoles per kilogram, despite having no fluid intake. After taking an ADH analog like desmopressin, which is the medication that works like ADH, the urine osmolality might return to a normal level, between 300 and 900 milliosmoles per kilogram, suggesting that the cause is a low level of ADH. This would be evidence for both central and gestational diabetes insipidus, which can be distinguished by looking at whether the person's pregnant or not. If the ADH analog causes urine osmolality to increase only slightly, then the kidneys aren't responding to the ADH, meaning that it's nephrogenic diabetes insipidus. Treating central and gestational diabetes insipidus relies on desmopressin to make up for the lack of ADH in the blood. For nephrogenic diabetes insipidus, drugs like thiazide diuretics can be given to increase urine excretion of sodium. Since sodium contributes to blood osmolality, getting rid of sodium reduces blood osmolality and stops the hypothalamus from stimulating thirst. In the case of dipsogenic diabetes insipidus, behavioral therapy can help reduce fluid consumption. Alright, as a quick recap, diabetes insipidus is caused by excessive water loss through urine. Central diabetes insipidus is due to ADH not being produced or released. And nephrogenic diabetes insipidus is the result of the kidneys not being able to respond to ADH. Gestational diabetes insipidus is caused by vasopressinase, which breaks down ADH, and is produced in the placenta of some pregnant women. And dipsogenic diabetes insipidus is caused by excessive water intake, commonly due to psychological conditions.
How does your body know when to retain fluids and when to get rid of them? It's not like you can just think to yourself, oh, I've had too much water, better get rid of some. If you do and that works, call us. But usually your body uses chemicals called hormones to send widespread messages, kind of like how the PA system at school tells everyone to ignore the smoke billowing out of the science wing. The antidiuretic hormone, abbreviated as ADH, is the hormone that controls water retention in the body. It also constricts blood vessels, and incidentally, the vasoconstrictor drug called vasopressin is just ADH. So anyways, the more ADH floating around in your blood, the more fluid you retain. The less ADH in your blood, the more fluid you excrete. Now, the nephrons in your kidneys are the structures that physically control how much water is excreted from your body. Nephrons are mostly a series of tubes attached end to end that move fluids and wastes toward the bladder. These tubes, though, also allow fluids and electrolytes to move through the tube walls and back into the blood if needed. ADH affects the last two-thirds of these tubes, called the distal convoluted tubule and the collecting ducts. These tubes focus almost exclusively on reabsorbing water back into the blood, and the walls of these tubes are unsurprisingly made up of cells, which is a common trait among living things, but these cells have proteins called aquaporins, and aquaporins allow water to move quickly in and out of cells. The more ADH floating around in the blood, the more aquaporins are available to facilitate water movement through the cell. So when ADH is low, most of the water flows through the distal convoluted tubule and the collecting duct, giving us diluted urine. When ADH is high, on the other hand, aquaporins grab much of the water passing through these tubes and throws them back into the blood. Now, when I drink a glass of water and that water is absorbed into my blood, my plasma osmolality drops, which means I'm diluting my blood with that water. And that means that there's more fluid for all those blood cells to bounce around in. The part of my brain called the hypothalamus sees this drop in plasma osmolality and tells the pituitary gland to slow down the release of ADH. Low ADH leads to lots of diluted urine, which brings our plasma osmolality back to normal. And that is a nifty feedback loop. Now suppose ADH continues to be released even though my plasma osmolality has dropped. We're going to continue retaining water, and as we drink more and more water, we might expect our plasma osmolality to continue dropping. However, this isn't really actually what happens. As more water is retained, it dilutes the other solutes floating around in our blood, like sodium. The extra fluid also takes up more space in our blood vessels. And this taking up of more space issue triggers another mechanism in our body that causes the hormone aldosterone to stop being released. Less aldosterone floating around in the blood causes the body to start dumping sodium from the blood into the urine. Concentration gradients cause water to follow sodium, so we end up with excess water being excreted in the urine with the sodium, which normalizes the fluid volume in the blood. So now our body is removing sodium from the blood that already has a low concentration of sodium. This means that plasma sodium osmolarity is dropping significantly. And this whole fiasco we just talked about is called syndrome of inappropriate antidiuretic hormone, or sometimes just shortened to SIADH. There are 4 patterns of ADH release in people with SIADH. Type A is completely erratic and is independent of the plasma osmolality. ADH levels tend to be very high, so the maximum amount of fluid is retained, causing urine osmolality to be very high as well. Type B is a constant release of a moderate amount of ADH. Type C is the baseline plasma sodium concentration level is set lower than normal. It's like you turn down the thermostat in your house to a new lower level. This type is particularly unique because the plasma sodium concentration is stable, unlike other SIADHs where it would continue to fall. And type D is the least common type of SIADH where ADH secretion is completely normal, yet urine osmolality is still high. The symptoms a person with SIADH experiences is caused by the dilution and loss of sodium in the blood. When your body has a lower sodium concentration than normal, you experience symptoms similar to dehydration or any other condition where sodium is low. Symptoms like headaches, nausea, and vomiting are common initially, along with muscle cramps and tremors. As the sodium concentration continues to get lower in your blood, though, the neurons in your brain begin to swell, leading to cerebral edema. This causes symptoms like confusion, mood swings, and hallucinations. And if left untreated, it can lead to the common downward trends that we see in most illnesses, like seizure, coma, and death. It's not hard to suspect someone might have SIADH. All we have to do is consider your symptoms in addition to your lab results. Low blood sodium levels and low plasma osmolarity combined with high urine osmolality and high urine sodium is a big giant red flag for SIADH. So what causes SIADH? Pretty much anything that messes with the secretion of ADH. Conditions like strokes, hemorrhages, or trauma to the brain can mess up the brain's ability to release ADH. Similarly, some drugs that act on the brain like mood stabilizers or anti-epileptics can change the way ADH is released. Surgery in general often causes an increased secretion of ADH, though we're not really entirely sure why. Obviously, brain surgery, specifically to the pituitary gland, also might cause extra ADH to be released. ADH can also be produced ectopically by tumors, which means the tumors themselves produce ADH outside of the pituitary gland and release ADH into the bloodstream. Small cell carcinoma in the lungs is the type of cancer most likely to release ADH in this way. Infections in the lungs and brain are also linked to an increased risk of ADH secretion. If some of your family members have had SIADH before, that means that there's a possibility you may develop it as well. The best treatment for SIADH is to figure out what the underlying cause of the excessive ADH is, and then treat that problem. Otherwise, we can manage SIADH by restricting your daily intake of fluid. You can also start a high salt and high protein diet to help replace the excess loss of sodium. Drugs that inhibit ADH secretion can also be used in chronic SIADH situations. For people who have really severe acute hyponatremia symptoms, hypertonic IV fluids are usually administered.